Good morning, teacher. My topic is linear IgA bolus dermatosis. Introduction. Linear IgA bolus disease is an autoimmune bolus disease which blister form on the skin and mucous membranes. This is a provoked case of character findings on direct immunofluorescence from a skin biopsy in which an IgA antibody like can be found just below the epidermis.
Hello, I'm Chika Ohata, Associate Professor in the Department of Dermatology at Kurume University School of Medicine. Our department has performed substantial research on autoimmune bullous diseases for over 15 years. I was the principal investigator for the study on linear IgA bullous dermatosis, LABD, without linear immunoglobulin deposition other than IgA at the basement membrane zone in direct immunofluorescence. We did the study because we noticed that LABD lacks common diagnostic criteria. In fact, some investigators believe that exclusive linear IgA deposition with no other immunoglobulins or complement deposition at BMZ in DIF is mandatory, whereas others believe that concurrent weak IgG deposition at BMZ in DIF can occur. However, in the latter scenario, patients may be diagnosed with bullous pemphigoid, linear IgA-IgG bullous dermatosis, or epidermolysis bullosa acquisita. Therefore, we thought it was important to study clinical manifestations and serological findings in patients with subepidermal blisters with only IgA deposition at BMZ in DIF. We retrospectively collected data for 101 patients who met these criteria and excluded patients who showed linear IgG and/or IgM deposition at BMZ in DIF. This study confirms the heterogeneity of autoantigens in LABD. Among the 101 patients, 54 had IgG anti-BMZ antibodies detected by either indirect immunofluorescence, immunoblotting, or enzyme-linked immunosorbent assays. No statistical differences in clinical manifestations were found between the IgG antibody-possessing group and the remaining group. Approximately 50% of this cohort exclusively had IgA autoantibodies, and the diagnosis of LABD is clear. However, the diagnosis of the remaining half cohort may be complicated. These patients could be diagnosed with linear IgA-IgG bullous dermatosis or simply LABD. If these patients are diagnosed with LABD, then consistency might dictate that patients with linear IgA and concurrent weak IgG deposition in BMZ in DIF should be diagnosed with LABD. We still do not have the complete answer to this perplexing diagnostic question. Consensus for LABD diagnostic criteria is urgently desired, even though it may be arbitrary. Thank you.
Application in nursing. Linear IgA bolus disease usually arises punctually, but can be treated by an infection or medication. Most patients with linear IgA bolus dermatosis improved or disappear weight reduction 1,500 mg daily. Pros and cons. The mucous membranes are affected in almost 19 of cases. Painful erosion occurs because the blister break. The most affecting are the oral, nasal, and conjunctive. What can cause scarring and shiny, and when they contour the cornea, they can cause discrete visual acuity and even blinks. You can do other mucosas, but less frequently, such as farting, labyrinth, rectum, and esophagus. Topic applied to Ecuador. A 72-year-old man developed Thames blister that affected 16 to 17 of his body surface, including the torso, lower abdomen, and back, and extremity. The biopsy shown subepidermal Bulloes dermatosis, while neutrophils and eosinophils consider idiopathic immunoglobulins IgA, idiopathic Bulloes dermatosis.
Linear IgA bullous dermatosis. It is one of the subepidermal vesiculation, and we may see neutrophils as a main inflammatory cells. And there is sometimes a scattered eosinophils and perivascular lymphocytic infiltrate. Direct immunofluorescence will show that linear deposition, which is the most important thing here, is the linear deposition of IgA at the dermal-epidermal junction, and that is usually 80% of the time. So linear IgA is heterogeneous subepidermal vesicular disorder. In children, the disease is referred as chronic bullous dermatosis of childhood, and both disorders caused by autoantibodies against the protein 97-120 kilodalton as degradation product of bullous pemphigoid antigen 2. Classical disease results in a group of annular lesions with tense body, it's also important, and we call it string of pearls. Drug-induced cases have been described using vancomycin. So we see here it is subepidermal vesiculation, and we see collection of neutrophil. This is a low power collection of the neutrophil, and sometimes some peripheral lymphocytes in the subepidermis and eosinophils. And when we do direct immunofluorescence, we'll be showing the linear deposition of IgA. Histologically, as you notice, that there is significant overlap with dermatitis herpetiform, but we see here it is linear by using direct immunofluorescence, so you have to do the direct immunofluorescence differentiate between them. This is a good picture for the IgA deposition, IgA dermatosis, bullous dermatosis, and obviously here we see linear deposition in comparison to what we see ragged deposition in the dermatitis herpetiform. The next entity is the bullous lupus erythematosus. It is subepidermal bulla with the neutrophils and immunoreactant to the floor with salt split skin, and we see other features of the lupus erythematosus. The last entity for subepidermal blistering or vesicular bullous disorder, the friction blister, where we see it is usually mid-epidermal necrosis, and we see serum may be present due to this friction. If somebody is using labor, hand with hammer or something, we'll see this friction blister, and it is not autoimmune related disease.
In conclusion, linear IgA bullous disease affecting adults of adult age, but is more common in old age, while though IgA dermatosis is a disease of very low incidence in international scientific community.
Hello, my name's Ian McComb. I thought what we'd do tonight is have a little look at some of the cases of linear IgA disease that are in Global Skin Atlas, and we'll also look at a little bit at histopath and treatment. The thing that's important about this condition is that there are two separate age groups in which it can occur. There's this case here that occurs in childhood, called chronic bullous disease of childhood, and the more typical adult linear IgA disease. Now, we'll look at some of these images here first. This was a lady who presented with some blisters and excoriated areas on her buttocks. You can see some of the blisters still out here, these areas of excoriation. Now, she was initially diagnosed as bullous pemphigoid, and she had been treated with high-dose steroids for many years without really good control. The question as to whether she had had a biopsy done before, she probably had, and it was probably just an ordinary H&E biopsy, and immunofluorescence probably wasn't done, because when we saw her later, we did do another biopsy and direct immunofluorescence, and it showed IgA in a linear pattern on the basement membrane, and not the IgG and C3 that you would see in bullous pemphigoid. Let's just have a closer look. The classic feature, though, are blisters that occur on a red base. And they're usually intact blisters as well, because the separation in this condition is through the lamina lucida. So they usually will heal without scarring, but they're like bullous pemphigoid. They occur as intact thick-walled blisters on a red base. The other thing that's important to remember, though, with linear IgA disease is that it can also be seen as a drug reaction, particularly to vancomycin, a drug that's used to treat severe multi-resistant staphylococcal infection, and also to captopril, which is a drug used to treat hypertension. Let's have a look at the histopathology of this condition. I think we'll look at this one. These are from Path Presenter. So this is an intact blister. You can see that it is a subepidermal blister. In other words, the whole roof of the epidermis. Well, the epidermis here makes up the roof of this blister. This is the dermal. These are the dermal papillae here. There's edema here. The cells that are in, these are red blood cells. Remember, in bullous pemphigoid, you would be looking for eosinophils. Now, in linear IgA disease, you can sometimes see eosinophils, but you're more likely to see neutrophils. And often those neutrophils are in the dermopapillary space as well, in a milder form, so that they can look a little bit like dermatitis herpetiformis. However, when you get splitting like this, this is much more the picture that you'd see in linear IgA than in dermatitis herpetiformis. In drug-induced bullous pemphigoid, eosinophils are often the predominant cell in the inflammatory infiltrate in this space. If you do immunofluorescence studies on this and do salt split skin, usually the IgA is in the roof of the blister. Sometimes it can be in the base, and that's because linear IgA disease is a heterogeneous disorder. There are various antigens that are attacked, including the bullous pemphigoid 180, and in some cases, it's even the collagen 7 that's attacked, and that's below the lamina densa itself. So you can get varying patterns just reflecting the varying nature of the heterogeneous nature of the antigens attacked in linear IgA disease. Let's have a little look at some of the other clinical cases that we have here. I'll do these adult ones first. This is another 76-year-old patient with linear IgA disease. This lady had been on vancomycin for an infected hip prosthesis when she developed these blisters on her elbows, dorsal of the feet, buttocks, lower abdomen. And in this one, it was linear IgA with neutrophils in the blister cavity. Now, we said before that sometimes vancomycin will have eosinophils in the blister cavity, so it can look a bit like bullous pemphigoid. But let's have a look at these. These mixture of blisters here, isn't it? Some of them don't appear to be occurring in the red base, others do appear to be occurring in the red base. They're intact blisters. So the thick-walled means it's deep split. Let's have a little look here at the abdominal wall. See, this could almost be the pattern of prebullous pemphigoid. You know, you've got this diffuse erythema, and if this was prebullous pemphigoid and you biopsied that, it would show you eosinophilic spongiosis. It won't show that in linear IgA disease. What else do we have? Again, just a reflection of that deep dermal erythema, that you get deep dermal hypersensitivity-like reaction, that you can get linear IgA disease as well. And the other cases that we'll look at, let's look at this one, because this is the classic for linear IgA disease in children. And it's then called chronic bullous disease of childhood. And if we look at this, this is a classic feature. There's a little ring of blisters around the outside of the lesion. Sure, some of them are burst here. There's crusts. Sometimes there's hemorrhage into these blisters as well. But again, you've got these intact blisters on a red base. And it's the peripheral location here. Look at the others up here in the groin, around the genital area. Let's have a look at some of the other images of this. Here we go here. Symmetrical nature of it again, red background, blisters, intact blisters in the red background, and sort of rings of blisters. Similar pattern here. Crusting, a bit of secondary infection there as well. Now, this was a 4-year-old boy, 7-month history of a vesicobullous eruption on the lower limbs, buttocks, and the face. Multiple clear round vesicles, Boolean erosions, marked erythematous background, and a string of pearls, cluster of jewel signs. The oral mucosa wasn't involved, but the oral mucosa can be involved in this, as it can be in linear IgA disease. The Zank smear is looking to see if there's virus, herpes virus. Now, this little boy's treatment was with dapsone, and a lot of linear IgA disease will respond to dapsone. Remember, there are neutrophils involved as well, and dapsone is quite useful for neutrophilic disorders. And dapsone itself is very useful for dermatitis herpetiformis. In fact, it's the drug of choice. Thing about this condition in children is that usually it will burden itself out. In other words, sometimes by the age of 10 to 12, the condition will just burn itself out, even when it occurs early on in a 4-year-old like that. This is a section in Medscape on linear IgA dermatosis, and this is just an example that they have in children. Again, often around the genital area, again, intact blisters on a red base. This was drug-induced, and it's curious to see blisters like this in the palm of the hand. But this was vancomycin-induced, and it was linear IgA disease. There is a variant of bullous pemphigoid that can present just like this as well. So you can see how difficult it is to make a definitive clinical diagnosis. You really have to excise a blister with a bit of surrounding skin to do your immunofluorescence studies. Remember, it's the surrounding skin that's the important part, because the deposited immunoprecipitants may be damaged underneath the blister area. You may not see them as well. So it's the skin adjacent to that that's important to examine. It's interesting. These were some other drugs that may be associated with linear IgA disease: amiodarone, ampicillin, captopril we mentioned. I think the vancomycin is easily the most common one that you can see this condition. But you can see some of these other drugs here that have been reported as causing linear IgA disease. And even infliximab, a TNF-alpha inhibitor, usually used to treat psoriasis, has indirectly perhaps caused that. Some of the PD-1 inhibitor drugs that are used in melanoma, they can, melanoma metastasis, they can, by unleashing the immune system, unlocking it, can often precipitate certain immunobullous diseases as well. I've seen a case of EBA, and it wouldn't surprise me if a linear IgA bullous dermatosis might come out in a patient on those sorts of drugs as well. It's interesting there. Linear IgA associated with, in 5% of cases, with underlying malignancy. So Hodgkin's disease, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, some solid tumors, bladder carcinoma. So yeah, you've got to keep that in mind as well when you see a case of linear IgA disease. And also in association with these other autoimmune disorders, these associations may be coincidental. This was the last of the clinical cases that we have here. 10-year-old this time. Look at the extent of the blistering. Big intact blisters. There is a background redness there, but it just gives you an idea of how severe the blistering can be in this condition. I mean, bullous pemphigoid can occur in children, but it's very, very rare. Mind you, this condition isn't common either, but it's certainly more common than bullous pemphigoid in children. Just a quick look at the other images. Again, that ring of pearls, of blisters around the outside of the involved areas, is such a characteristic feature. Cluster of jewels, string of pearls. Okay. Linear deposits are both IgA and C3. I must admit, it's more IgA rather than the C3. You know, IgG and C3 is the picture that you see in bullous pemphigoid with immunofluorescence. I'd also advise you to have a little look at the dermatology online. It's probably one of the better resources if you want to do a search for some of these diseases and some of the variations that you can in fact get in this if you're looking at the histology, especially the immunofluorescence picture. So you can see there's a wide range of articles here on this condition. So, as I say, we've got some good images here in Global Skin Atlas, and I hope that gives you a better idea of the histology of this condition and the treatment essentially with dapsone. With oral steroids can be used, but they're not the primary drug as they would be in bullous pemphigoid. Thanks very much.